Hi, my name's Sue Mallet. Welcome to this short course on designing diagnostic test accuracy studies, the absolute essentials you need to know. I work at the Centre for Medical Imaging at UCL in London in the UK. I'm going to share with you important tips I've learned in designing these studies over the last 20 years. The Introduction to Diagnostic Test Accuracy Studies is a series of short videos, each highlighting a key learning point. In each video, there are short activities where I encourage you to pause the video and think. If you're watching with colleagues, this is a great opportunity to discuss together. After each activity slide, I'll share with you my thoughts and insights. We're on part 4, cross-section and cohort studies. So let's take the objective we had in part 1, where we're trying to design a diagnostic accuracy study of persistent cough for diagnosis of lung cancer in primary care. And the question we're going to be asking is, will this study design give us a good estimate of clinically relevant test accuracy? So I'm going to show you two different designs. So here's the first design, where we've gone into the hospital database and we found a series of patients. Okay, and I tend to think of the study as this sort of study design is a bit like this. So we're in the hospital database and we found the histology results for where they got the diagnosis of lung cancer. And then we look through the notes and work out whether they were recorded as having a cough at the time that they came to the hospital. And then we compare the two sets of results and we look at the diagnostic test accuracy. Okay, so will this study give us a good estimate of clinically relevant diagnostic test accuracy for diagnosis in primary care? Okay, so one of the issues here with this study design is we actually know at the start whether the patients had the disease or not. So these are patients from the past, they're in a database, and we're looking through and we're finding the ones with cancer and the ones without cancer, and then we're looking through for where they've got a cough. Okay, but also there's a second problem, isn't it? And that's that, notice we only have the patients who were referred to hospital. Okay, so you might think, well, this is a bit of a bizarre study design, no one would ever do this. But actually, this is really a common design, and it's particularly common when people are looking at new biomarkers. And that's because what they'll do is they'll want to evaluate a new biomarker, maybe based on histology. And so what they'll do is they go off and they'll open the freezer door and they'll take out samples from patients with and without cancer. And these will be patients who've given ethical permission to have their tumours taken out from them during surgery, used for ongoing clinical research. And so then you'll test your new biomarker on the samples in the freezer, and then you'll look and see whether they had lung cancer, and then you'll look at the accuracy. So this is actually a really, really common design. Okay, so here's another design. This is where we want to know the accuracy of the cough in primary care. So we actually go to the GP and we recruit a set of patients from the GP, and they look more like this. And then they're asked whether they got persistent cough, and that's recorded in their GP record. And then we look at the follow-up tests and find out whether they actually developed lung cancer, including imaging and histology that we link with. And then you do a 2x2 table of those results and get our accuracy of persistent cough for diagnosis of lung cancer. Okay, so notice here that we're actually testing for the persistent cough before we know whether they've got lung cancer. So that's great, that's a positive. And also notice that we are actually here including patients who don't get referred to hospital as well. So again, that's a real positive. We've actually got something that looks more like the real patients. So this feels much more comfortable than the other design for actually getting a proper estimate that we could use in clinical practice. So there we can see that the ideal diagnostic studies have a cross-sectional design. So we call them cross-sectional studies. And that's where the index test and the reference test are done at the same time. Now, in that study we're just showing you, actually it was in a slightly less ideal situation, where to get the reference standard we needed a later time point. And you can see that for the test done in primary care, then they get referred on to the hospital, and then they get a biopsy or surgery, and that's how we get the final confirmation of the cancer. So those can still be a cross-sectional design, but where there's a little bit of a follow-up to get the reference standard at a later time. And again, that's quite typical of a lot of studies. So as well as that, we have these studies that can be at a higher risk of bias, where we've got a selective recruitment of patients after the reference standards are known. And these are often known as case control studies. Now, for some diseases, such as really rare diseases like 1 in a million or 1 in 10 million, we can't recruit everyone. And actually, this can be the only study design we can do. But in a lot of studies, we can do better than this. And a lot of studies you see using these case control designs in diagnosis, when actually you think, well, I could have done a bit better. And these studies quite often are using 2-gate case control designs, where they use a different inclusion criteria for the people with and without disease. And these are really problematic, because then we're not actually sure who we're going to apply it to in the future when we've got the result. And so one of the issues with these studies is thinking about the patients that we missed with our study design. So I'm going to describe a PSA, which is a blood test used for prostate cancer, just to illustrate the issues that are going on. So this might be the result. So here we've got the number of patients on this axis, and then we've got the level of PSA in nanograms per mil on this axis. So here we've got measurements from people who don't have cancer, don't have prostate cancer, and they're shown in green. Okay, and this shows us the distribution of their results for PSA. And here in red, and little red men, is the distribution of the PSA values for the people who do have prostate cancer. And one thing to notice is that these two curves overlap. Okay, and so what we have to do is we have to pick a threshold, and we have to say, okay, we're going to call it a positive PSA test if it's above this threshold, and negative if it's below. And what we can see here is that there are some red men who actually do have cancer who've got a PSA below 4, and they're going to get a false negative result. And we've got some green men who've got a result above 4, and so they're going to get a false positive result, even though they don't have cancer. Okay, so in a cross-sectional study, where we've got a clinically relevant set of consecutive patients, these might be all the men in our study. Okay, and so these lot have all got their PSA level below 4, and this lot of men have a PSA level above 4. Okay, and what we can see is that there are some red men who are below 4, and there are some green men who have a PSA value above 4. Okay, but this is what the patients recruited to a study might look like if we were doing a 2-gate case control study, where we were taking people with extreme disease and we were taking healthy controls. So here's our healthy controls. They got really low PSA value, and here's our extremely severe patients, and they've got really high levels. And so, you know what, this test looks amazing. Everyone gets a correct result. So, it's almost too good to be true, isn't it? And, what you can see is we've actually missed out on a lot of patients in the middle. So these patients in the middle are missing. Okay, and that makes the study at high risk of bias. Okay, here's a case control where we're doing retrospective, typical, retrospective via clinical notes. And again, we've got, more of a range of men with red results, and we've got more of a range of men with green results. If you just based your accuracy on this set of patients, you'd think the test was pretty good. And that is at high risk of bias, again, because we're missing the typical patients in the middle. Okay, if we did a nested case control, where we randomly sample from this consecutive set of patients, we actually end up with a set of patients who are pretty similar to the normal cohort. So either using the cross-sectional study with a clinically relevant consecutive patients, or using the nested case control study from the cross-sectional study of clinically relevant patients, we end up with results that are at a lower risk of bias in how the patients have been selected. Okay, so in diagnostic accuracy, we're still trying to coordinate, so we're all using similar terminology to describe these things, but we're not there yet. So these sort of words, cross-sectional design, cohort design, nested case control design, those are words that may suggest your study might be okay, but again, look closely. And here are words that suggest your study design might be problematic if you have case control, healthy controls, or retrospective identification of patients. These characteristics in a study can indicate a high risk of bias. Okay, so your turn now. I'd like you to do a little pause and think exercise. I want you to actually, what the aim is to get a study design that will get accurate values of test accuracy. And what I want you to do in your pause and think exercise is I want you to think about why most case control studies give inaccurate estimates and why nested case control studies are okay. And I've given you this diagram again to help you frame your answer. Hi, welcome back. I'm hoping that you are framing your answer about why case control studies are typically give less accurate results around the people who are missing in the middle here in these case control studies. And that you are also thinking about how a nested case control taken by random selection from a clinically relevant consecutive patients would still be a good design, even though it's got the words case control in the title, because it's actually covering this full spectrum of the patients we'd expect in normal practice. Okay, so it's really, we need to concentrate on the low risk of bias and selection of the patients in the study design. That's really important. Okay, here's another pause and think exercise for you. What I'd like you to do is think about whether these two study designs will give you the same values for sensitivity and specificity, even though they're done in a different way for our objective of accuracy of persistent cough for diagnosis of lung cancer in primary care. And I'd like you to also name which one you prefer. Hi, so I hope you took the opportunity to pause and think about what might be going on in these two studies. So in this hospital database, we've got patients who are already diagnosed with and without lung cancer. So this is a case control study. And that means because of the way the data is collected, we may be missing patients. So we won't have included the patients who didn't attend hospital. We may be missing the patients who didn't have a cancer diagnosis. And we may be also missing patients who attended directly at ICU. And I'd like you to also think about and notice that the cough was actually done at the wrong time point. So we were really interested in whether they coughed in primary care, but if they were reporting whether they coughed when they were at the hospital appointment, that's a completely different time point from primary care. And maybe that may affect whether mild coughs are included or not. So what we know from this study is we know specificity will be overestimated. So we'll be missing the false positives that might have come from patients who didn't attend the hospital and who weren't referred to hospital. With sensitivity, I'm not sure what will happen. It could be overestimated or underestimated. I'm guessing it'll be underestimated. So why I'm guessing that is because there'll be inconsistent reporting of the cough in the hospital notes, because it may not be considered important if it's not a test being used by the clinicians in the hospital. There will be a possibility it's overestimated because we've got more severe patients, but I think overall it'd probably be underestimated. Okay, so we've got a problem with both the sensitivity and the specificity, so this is not a great study design for this question. Okay, when we're actually looking at the other study design, where we're recruiting patients from the GP, from primary care, we've got a much better design. So we're actually also able to measure the persistent cough at the correct time, when we wanted to know about it in primary care. And it's also at the time, because we didn't know the disease status of the patients at the time the cough is being recorded. We've also missed out on any biases there, and we've also missed out on when the doctor decided to report it and decided it was serious, and they would take that appointment. So we've reduced our number of biases there might be in the data. But we have also got the patients who have coughs from other conditions in primary care, which are nothing to do with lung cancer. And so those are going to give us, correctly, lots of false positives for cancer. So lots of people with persistent coughs where it's nothing to do with cancer. So what we're going to get here is we're much more likely to get sensitivity and specificity results that are relevant to clinical practice because we've got the right set of patients. We're doing the test at the right time in their patient pathway. So, did you do well in the activities? Well done. And I look forward to seeing you in part 5 when we're going to talk about early phase or clinical phase studies.